Broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. Thank you for joining us this morning. We are incredibly privileged and honored to have with us today Dr. Marian Earls. She will be talking to us about healthy social emotional development in young children. Dr. Earls is the director of pediatric programs for Community Care of North Carolina. And we are very lucky at the North Carolina Early Childhood Foundation that she is a member of our board of directors, and in fact is a founding member of our board. The foundation works on ensuring that each North Carolina child has a strong foundation for health, well-being, and education, supported by the nation's premier birth to 8 early childhood system. And we do that by promoting understanding of the early years and what is happening for young children between birth to 8. We focus on collaboration and supporting systems and disciplines in coming together. And we also work on advancing policy. We take a whole child approach to young children. So we focus again on birth to 8, thinking about children's health and development being on track, beginning from birth, supported and supportive families and communities, and high quality birth to 8 learning environments with regular attendance. So those are the areas we focus on. Many of you are probably familiar with Dr. Earls. She is nationally known for her work. She's board certified in both general pediatrics and developmental and behavioral pediatrics. She was the chair of the Mental Health School Committee for the North Carolina Pediatric Society until 2001, and she's also a past president of the Pediatric Society in North Carolina. She was the lead author on the American Academy of Pediatrics clinical report, incorporating recognition and management of perinatal and postpartum depression into pediatric practice. She is a liaison from the American Academy of Pediatrics to the American Academy of Child and Adolescent Psychiatry. She has a very long bio because of her many accomplishments, which you can read on our website. I do also want to point out that she was co-chair of the North Carolina Institute of Medicine's task force for the prevention of child maltreatment, and also on the early childhood mental health task force as well. Many of us know her work on the ABCD, Assuring Better Child Health and Development Project. We are fortunate as a result of this work that North Carolina has the highest rate of developmental screenings in the nation, and that is largely due to Dr. Earls's commitment and dedication to continuing to move this work forward. So we have a lot of people on today's webinar. So what we'll do is Dr. Earls will give her presentation. As she's presenting, if you have questions, please type them in the questions box, and then we will save time at the end to address them. Thank you. And thank you, Dr. Earls, for joining us.
You're welcome. I'm glad to do this. This is one of my very favorite topics. So we can get started here. I do want to say, there's a lot of information here. I recognize that we have folks from a variety of different disciplines and professions, and that's exciting. So roughly what's going to happen is I'm going to talk a little bit about the background of what things that we know about social emotional development in young children. I'm sure many, if not all of you, have heard information around early brain development and the impact of toxic stress and ACEs and social determinants on healthy social emotional development and health in general. But we also are learning some things about protective factors and resilience. So we'll talk a little bit about that. Given I'm a pediatrician, I do want to talk a little bit about what the role of the medical home is, and talk a little bit about what the AAP, the American Academy of Pediatrics, is recommending to those who provide primary care to young children, how we should be promoting social emotional development, how we should develop competencies in early childhood mental health and child mental health generally. And then I want to really, in the spirit of a strengths-based approach, talk about what we have in North Carolina that are strengths in this area, and then also talk about what our gaps are and make some have some discussion a little bit about what some of our policy needs seem to be. So, okay, Tracy, why don't we go ahead and change the slides? So I always like to start out about things that we know that experience has an impact on brain development. We know that growth and development and behavior are inextricably linked. Tracy mentioned that the foundation is very interested in the whole child, and in no place is it more evident than in young children that those things are all linked. And emotional development occurs in the context of a relationship. So bonding and attachment, reading a baby's cues are also important. Okay, next slide. You may have heard this terminology about serve and return, but what we realize is that those kinds of interactions actually shape brain architecture in young children. And so these are incredibly important to the development of healthy social emotional development, but it also has an impact on learning and cognition as well. So next slide. This is a really nice slide from the Center for the Developing Child at Harvard University. Many of you are aware that's the leadership there is Dr. Jack Shonkoff, talking about stress response in children. So, you know, if you have a stress response, that you get this brief increase in your heart rate, some mild elevations in your stress hormone levels. Some of that is actually positive. We learn from that. So we get somewhat stressed. There's relief of that stress, and it helps with learning coping skills. There's tolerable stress. There might be some serious stress responses, but when it's buffered by a supportive relationship, that is very protective for kids. And then there's toxic stress, where there's a prolonged activation of the stress response system, and there's not that presence of a protective relationship. So the next slide. So this is your neurology lesson for the day. We won't get into all of the detail here, just to explain that when the physiologic stress system responds, the elevation of cortisol affects these areas of the brain. And what's important to realize is those are areas of the brain, again, that are related to social emotional development, but also to memory and language and cognition. But the other thing that toxic stress impacts is the immune response. And so now there's lots of interest in what does that mean long-term for children and into adulthood for chronic health problems. And then finally, a new emerging area, which we can't really spend time on today, is the area of epigenetics and how these stressors seem to actually have an impact in genetic expression. So next slide. Can you change the slides, Tracy?
Do you see the one?
There we go.
Also.
Oh, it just went twice. So the other area is the area of adverse childhood experiences. If you can go back one.
Yep.
So I imagine everybody has heard about ACEs. Here's the list of ACEs. And actually, if you think about things that might be exceedingly disruptive experiences for children, you may be able to think of a couple others. When the studies were done, these were the areas essentially around neglect and abuse, and then family disruption and interpersonal violence that were identified as adverse childhood experiences. Next slide. Now, what we know from that is there's a dose response. And so I want to call your attention here to what that means. For children with 3 or more ACEs, they have 3 times the chance of academic failure, multiple times incidence of behavior problems, attendance problems at school, and then you can see into adulthood, those ACEs have very serious health implications. So if you think about some of the children that we're talking about here, we have children who are entering foster care, who may be entering foster care with 3 ACEs already. We have kids who live in situations that are very stressful. So you know that this is something that's fairly prevalent, and that was one of the things that the folks who did this study actually found, that ACEs are actually more prevalent than you might expect. So next slide. So the other area that now you hear a lot of discussion about are social determinants of health. And I just want to point out here this diagram from the Robert Wood Johnson Foundation, which is really helpful to look at health outcomes. And if you look closely at that, the clinical care only accounts for about 20% of our health outcomes. But look at the things that are circled here, the social and economic factors, the physical environment, how much of an impact those have on health outcomes. Probably not a surprise to many people who've worked with children and families over the years, but something for us to really think about. So next slide. So this is just a depiction of multiple social determinants of health that have an impact on people's ultimate health outcomes. And you can see that all of these things are things that we consider when we're working with young children and their families. Next slide. So this is a study around social determinants of health in early childhood that came out of the CDC about factors associated with mental health or behavioral or developmental disorders in early childhood. And if you look at what factors really bubbled to the top that affected those areas, mental health, behavior, and development in young children, all those things come under those categories of social determinants of health. So just something to keep in mind. Again, those of us who work with young children are very aware of the fact that many families come to us with a lot of these issues, but we should be particularly vigilant in how we are supporting those families and young children. Okay, next slide. So not to be all gloom and doom, there are social determinants that actually protect health, in addition to those social determinants that can actually place health at risk. And these are things that, you know, if you thought about it, and if you've worked with young children in whatever capacity, whether in education or in health, these things, we are aware that they do make a difference in how children and families do. So these are the sorts of things that we, at the American Academy of Pediatrics, are really trying to encourage people to help promote with families and to link families to the right resources to improve these things. So the next slide. This next slide is probably familiar to many folks. This is from the Center for the Study of Social Policy in their Strengthening Families framework. But these are areas that relate to that previous slide we just saw, the social determinants that are protective. And CSSP has actually partnered with the American Academy of Pediatrics to give providers some ideas about how do you go about promoting these protective factors with families. So next slide. The thing that we're really identifying because of this information that we have about early brain development, about ACEs, about social determinants, is this two-generational approach to health. So there's not a way that we can really work with young children without also working with their parents and their families. And parents and families together can really adapt positively, identify resilience factors, and to do better. So the next slide, another one of my favorites from the Center on the Developing Child. If we really want to achieve breakthrough outcomes for children experiencing toxic stress, then we have to transform the lives of the adults who care for them. And then next slide, I'm not going to read this definition to you, you can read, but this comes from the American Academy of Pediatrics Center on Resilience, the Resilience Project, which grew out of the work on toxic stress. And it really just recognizes that there are folks who have, even though that there has been a traumatic event, have protective factors to move through that and still experience success. And this is the area where we're really admonished to promote that resilience as much as possible with families. So next slide. I'm going to talk a little bit about what that means in the medical home, what that means around health. Next slide. And just to clarify definitions, this is the American Academy of Pediatrics definition of medical home. That it's accessible, that it's family-centered, that the care given is continuous, it's comprehensive, it's coordinated. And what coordinated means is that you are coordinating with multiple community partners in working with families and linking families to the things that they need. It's compassionate and culturally competent. Next slide. But those of you who know me know that I always say it also means caring for the whole child, considering physical, developmental, and mental health all together, and not separating the head from the body. So the next slide. The American Academy sort of guidelines for preventive care is called Bright Futures. Our most recent edition came out last year, and it emphasizes all of the many things we do to take care of children and their families and to promote their health. There's a couple of new emphases in the Bright Futures that people should be screening or asking about social determinants of health at every well visit, and along with that, be eliciting and discussing parental strengths and protective factors with families at every well visit. So there's, some unique opportunities in pediatric primary care. Some of this information comes from the work we've been doing at the American Academy of Pediatrics around childhood mental health, not just young childhood, but all children and adolescents. And because in the pediatric medical home you have a longitudinal relationship with families, you have an opportunity to identify emerging issues at an early stage, and to work in partnership with other practitioners to improve care and enhance preventive services. And the next slide. And the other uniqueness of pediatric primary care, it's about promotion and prevention as well as intervention. We are familiar with developmentally appropriate behavior. We can help primary care clinicians and families understand whether a behavior is a typical behavior or a concerning behavior. We can maximize the functioning of the child. And the real importance of this work is that there's a long-term return on investment for doing this kind of work with kids. So next slide. So I developed this slide because I wanted to really be able to talk about the fact that these are things that are really possible to do in practice. So I just showed you things that are recommended, and people say, can that really happen in the medical home? And in work that I've done around the country with training practices on implementing these approaches with families, these are the things that we've seen. So what we hear from folks is that if you are routinely asking parents about strengths and talking to them about it, it's transformative to practice. It's transformative to the relationship. It is possible to discuss difficult things like social determinants because we're talking about both those that increase risk and those that are protective. We know from experience, there's been lots of folks looking at asking families about ACEs, and they're really beginning to understand that resilience can ameliorate that impact. Folks are really grasping trauma-informed care and putting a focus on promotion and prevention. Engaging families as partners makes such a world of difference in the success of this work. And promoting resiliency is central to addressing these things. So I say all of this because I think this has such an impact on children's early social emotional development. I'll make just a comment about mental health integration in primary care. In pediatrics, there's a major push to do this, that folks apply these approaches in their care, and also consider having a person who knows something about children's mental health, and particularly about early childhood mental health, as a member of the medical home team, removing stigma and being a part of the team in doing promotion and prevention in the practice. Next slide. There we go. So this is a busy slide. We're not going to spend a lot of time on it, but I did want to share with folks some of the work that we've been doing at the American Academy of Pediatrics to try to promote this idea of mental health integration in primary care. The benefits of it are amazing, those folks who have been able to do that. And we realize it's a range. If you're in rural North Carolina, you may not be able to have people co-located in your practice. But we can develop relationships and coordinate care so that for families, it's a continuous process and it's not fragmented for them. So enough about that. We'll mention it again when we start talking about policy. So next slide. So a little summary about early childhood mental health. We've just discussed that development and behavior are inextricably linked. And the other issues around early childhood mental health are that these are the sorts of things that young children may present with don't meet criteria for traditional mental health diagnoses from the DSM-5, which is the diagnostic classification for mental health diagnoses. There is a diagnostic classification for 0 to 5-year-olds that was developed through the 0 to 3 organization nationally. And I mention this as well because it's going to be important to the policy work that we're trying to do in North Carolina. And the other thing about early childhood mental health is therapeutic interventions are necessarily dyadic, right? It's going to be parent-child. It can't be just the infant. I always make the joke to folks that, the 6-month-old isn't going to lay on the couch and talk about their mom. This is really dyadic work that we need to do with early childhood mental health, and it's what makes it pretty unique. Next slide. And just to mention, because folks may have heard of these, there are evidence-based therapies and interventions for infants and young children. You can see that list there and the ages that they cover. And these are areas that more and more everywhere in the country we're recognizing the need to have folks who actually can work with families and promote mental health in young children by being able to implement evidence-based therapies. So let's shift gears here, next slide, and I want to talk about North Carolina, our systems and policy and workforce current state and things that we might need to do in order to promote infant and early childhood mental health or healthy social emotional development. So again, as I mentioned, taking a strengths-based approach, I want to just briefly review for folks what's going on in North Carolina, and then we can talk about what gaps we have and where we might want to go. Just to give you a little perspective on this, we're not unique in that services for mental health in children generally are limited, but as you see highlighted here, there's insufficient numbers of mental health specialists who work with very young children, and there's not a lot of support in our traditional mental health services around emerging and mild and moderate conditions, which are going to be more common in this young age group. So next slide. So let's talk a little bit about systems here in North Carolina and those that are strong for us. Next slide. I'll move through these a little bit quickly because Tracy did mention this. So in North Carolina, since 2000, we've had an Assuring Better Child Health and Development project. It was originally funded by Commonwealth Fund, and we started to implement it as part of Community Care of North Carolina as a quality improvement project with practices to try to get them to integrate developmental behavioral screening as a routine thing in their practices to promote early identification, do promotion around development, and then link families effectively to resources. So the next slide, just a little bit of data about our group. It started out that we worked on developmental screening, then we realized, oh, we're missing things. So we expanded that to autism screening and then to maternal depression screening in the infant visits. And now we're actually working to move towards more routine social emotional screens and social determinants of health. You can see we've had a state advisory group. It's included multiple folks from health and from early childhood education, from home visiting. It's quite a list of us that meet. We've been meeting since 2000 to work on administrative and policy barriers and to build consensus. And we also have a quality improvement group that works with practices around the state to really assist folks in doing this well, primarily around how do you engage families and get them linked to things, resources that they need. Next slide. And just some data about this. We've been able to develop consensus on how we talk to each other, how do we get feedback to medical home, how do we support families and make sure no one slips through the cracks. And you can see we have very high rates of people doing this screening. Even maternal depression screening, which is very new. People are very aware of how important it is to support moms early on. So next slide. Some more strengths are our Project Broadcast project that has a huge effort to bring trauma-informed practices into the child welfare system. We have the North Carolina Child Treatment Program, which is dedicated to really expanding evidence-based treatment models, and I'll mention them again, and those are those same therapies that you saw on the earlier slide. We now also have Child First, which is an evidence-based home visiting model. It's right now only in the eastern part of our state, but we hope that that will be able to spread to be available to families, so they can take referrals from DSS. They can take a referral from a primary care medical home. They could take a family referral if there's a family that's experiencing these kinds of significant social determinants of health or depression, or the family's at risk for neglect or abuse. And the other system strength we have is North Carolina has always paid for dyadic therapy under the child's Medicaid, which is really awesome. Next slide. So again, as I mentioned, these emerging system strengths, largely because of the work of the Child Treatment Program, you can see that we have increasing numbers of folks that have been trained and are able to offer these evidence-based programs. However, even when you look at some of these numbers, you realize, oh my goodness, we have 100 counties. 10 people trained in something cannot possibly serve families across the entire state. So we still have a long way to go on this one. Okay, next slide. So around health policy, we can go ahead. Next slide, can you move it, Tracy? Mine's not moving. There we go. So early on in North Carolina, in 2001, in the work of the Pediatric Society with our North Carolina Medicaid folks, we were able to get mental health care for children that allowed for what we call unmanaged visits, and you didn't have to have a diagnosis for those visits, which really recognized how commonly with children we have a presenting issue. Maybe there's even some functional issues, but they may not have an actual diagnosis. And this allows for folks to be able to serve young children and actually address some of the issues that may be going on for a family before anybody is waiting to see if there's going to be a diagnosis emerge. So this was really monumental. And when I talk to people in other states about this, it's really wonderful that we were able to do this. Next slide. We have had a group for the last year and a half working on infant and early childhood mental health services through the 0 to 3 organization. We were one of 10 states. They've been helping us identify how can we move policy to improve these kinds of services for young children. And you can see here we are able to provide the dyadic therapy, which is wonderful, and based on the child's Medicaid coverage, we can offer therapy in different settings. And under EPSDT, which is the well child provision under Medicaid, their there can be reimbursement for services beyond other kinds of policy limitations. So that's really wonderful. And the next slide. North Carolina also happens to be a leader in primary care mental health integration in pediatrics. Here at Community Care of North Carolina, the last couple of years have had a national grant to work on how to implement integration in primary care, and you can see that there are about 60 practices in pediatrics that are working on this or are doing it very, very well, and there's about 7 family medicine practices doing it. So people are working on the reference there at the end is the main self-assessment for practices around integrated care. So we have a large number of practices that are offering those services for families, and we hope that that will continue to grow. So next slide. The other area that we really want to identify is the workforce development area. And we do have some strengths here and also some needs. So I have a couple of slides here just describing what the North Carolina Infant Mental Health Association has been working on for the last couple of years. They have developed social emotional competencies and have competency based on provider categories. So you can see there anyone that works with children and families, or someone who might be working with young children in a non-clinical setting or in a supportive role or in an early childhood classroom. And then the third category, those with an advanced degree, those with working with children in a clinical setting. And next slide. This just shows the domains for those competencies. They probably seem fairly obvious to you, but we are very interested in being able to advance training on these competencies to a variety of disciplines of folks. And then the next slide. I'm sure many of you are familiar with CSEFEL, the Center on the Social and Emotional Foundations for Early Learning. That has training, a pyramid model for training for preschool and infant toddler around teaching skills and ways to develop behavior support plans. And here in North Carolina, on the next slide, as part of the North Carolina Early Learning Network, the CSEFEL materials have been well developed with classroom materials, ways about disciplining that's available on that website. We know that our Part B exceptional children preschool folks have been working very diligently on this for at least a couple of years now, and doing lots of great work with teachers who are working with children in that 3 to 5 age range. Next slide. So let's get to what we need. And there's a list here, and I'm hoping we have some time to actually have a little discussion about people's experience here. We're really looking for the requirement in the request for proposal for Medicaid reform that any plan that would come to North Carolina would meet our current standards for North Carolina EPSDT and support the quality efforts that the ABCD project has been doing for a number of years, and that those plans will continue the work in the medical home or supporting the work in the medical home to support children's early social emotional development. We are very concerned as we move forward with that reform that the Care Coordination for Children program, which are nurses and social workers who are employed by public health, who work with children 0 to 5, who have any kind of risk. So it's a wonderful program in terms of being able to work with families and be sure that folks don't drop through the cracks, that the people get connected with services, and they work very closely with children's medical homes. We need a system for disseminating the social emotional development competencies across disciplines. And we need support around mental health professional collaboration with primary care and early intervention in particular. Our early intervention program addresses kids' developmental needs, but they don't typically have folks that are trained in early childhood mental health, and so that collaboration will be very important. Next slide. So around health policy, we're very interested in having the diagnostic classification for 0 to 5-year-olds be recognized in our Medicaid policies for mental health professionals who are seeing children that young. We are interested in practitioners that having actually a credentialing system that they work with infants and young children, and that folks are trained in evidence-based practices. And as I told you earlier, we're doing some work in this area, but we still have a long way to go. Next slide. These are some other health policy things that we're interested in. We want to have continued support for mental health integration in primary care. There are a lot of administrative barriers to that we would like to be able to move past, so that that this is possible for primary care for those folks to be part of the medical home team. Because of our carve-out mental health system, it's been difficult credentialing mental health professionals when they're integrated in primary care. Our system also has made it difficult for children in foster care, if they're placed out of county, to get services in the new county where they're placed. And we know from the earlier slides that children in foster care are likely to have experienced many ACEs, so we know that they need to be able to receive the services. Because of our shortages of child and adolescent psychiatrists and mental health professionals who serve this age group, the need for consultation that's not face-to-face for primary care to be able to consult with someone in a rural community, being able to consult with the appropriate professionals. That's something that we need to have happen. And as the American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry suggest, not having a carve-out system for mental health is better for children's mental health. And then next slide. Around workforce, I've mentioned this in a variety of ways so far. We really need workforce development around mental health professionals who do work with this age group. We need training of that workforce on the diagnostic classification for 0 to 5-year-olds. We need collaborators and resources to train on the social emotional competencies that are available for a cross discipline. And I think it's important to note that that need is around pre-service training and in-service training for folks who are already doing that work. And a lot of that training also involves trauma-informed training, and that everyone has that exposure to what are the trauma-informed principles. And then finally, around social determinants of health, you may be aware that our Department of Health and Human Services has actually pulled together folks from a variety of agencies and services to discuss how do we move towards regularly including asking about social determinants of health for folks that are coming into healthcare in any way. We need recognition of that. We need education regarding the risk of social determinants in early development and the impact on long-term health. We are very interested in being able to make social determinants of health a factor for eligibility in the early intervention system in Part C. Those of you who've been in the state long enough may know that many years ago we were a state that if a child just had risk, they were eligible for early intervention, but because of years of funding restrictions and so on, that has gone away. We would like to, especially with what we know now about early brain development and the importance of addressing social determinants, this seems to be even more important for us to do this. And of course, we're going to need capacity of our community resources. So I moved as fast as I could, Tracy, and I think we have some good time for questions or discussion.
Yes,
or brilliant ideas.
Thank you so much, and I apologize. It seems that there may have been a delay as I was advancing to you seeing them, so hopefully it certainly didn't throw your game off in terms of how it sounded, but apologize for that. As we mentioned at the beginning, go ahead and type questions in the question box, and we will have time to address some of those. The first one I'm seeing is around looking at some specific programs or approaches. So is there potential for expansion of integrated care or programs like 0 to 3's Healthy Steps program, which co-locates a parenting support expert in a medical practice?
That's a great question. I wonder if that person is from Guilford. Guilford County is actually moving in this direction. They're placing Healthy Steps folks in a few practices there and hope to expand. So for those who don't know about Healthy Steps is a program that actually developed around in the years just before the ABCD project started with Commonwealth Fund. And it really places a person with expertise in early childhood development in a primary care practice. And what it has evolved to is, the possibility of that person actually being an integrated professional. One of the limitations, as many of you might be able to imagine, is how do you get payment for having such a person in your practice? So Healthy Steps is moving in that direction to try to identify ways that it will be possible to integrate a Healthy Steps person in a practice and still have that be something that is affordable for a primary care practice. But the ability to be doing screening in a practice, and then when there's a concern that arises, to be able to have somebody right there in the clinic with that expertise to do a warm handoff, to be able to talk to that family real time and also assist with connecting that family. The possibilities of that are really very excellent. I will say that the practices in the state who have already, pediatric practices who already have integrated mental health professionals are doing some of that with these young children already. So that if there's a positive maternal depression screen, if there's a positive screen around development or social emotional development, very often those folks are part of the team that talk with that family that day to make sure that it's not just, oh, we found this and you need to call. We've really tried to make sure that integration is possible so that we just know that if there's that kind of support, families are more likely to get the linkages that they need.
Great. So here's another question. Are there specific policies that child care programs should enact to support healthy mental health development for the children and families they serve?
That's really a great question. I didn't have a lot of time to talk about the CSEFEL, but I did a presentation for the National Association of Young Educators of Young Children last year with some colleagues from the American Academy of Pediatrics, and we actually talked about the fact that the Center for the Study of Social Policy actually has some recommendations around those family protective factors for policies for early childhood education settings, but also the Caring for Our Children guidelines, as you may be aware, have lots of recommendation around mental health consultants, the use of mental health consultants in childcare and the support for that. And that's not something I really talked about today, but it is a need. I know that at the 0 to 3 conference just a couple of weeks ago, states were talking about how do they support mental health consultants for early childhood settings. Where is that support in the state? So I think that exploring something like that is a really important thing, and I'd be glad to talk to somebody offline a little bit more on the details of those recommendations out of Caring for Our Children.
Great. Okay, so this one is about funding. Is there additional funding being discussed for evidence-based program training for clinicians? This has been a significant barrier for many individuals, as not only are they paying for training and related costs, but they are also out of work for those dates.
It's a great question. And we've actually had discussions about that on our infant and early childhood mental health team, because and if you may be aware that the Infant Mental Health Association did a survey, I think it was last May, so it's been a year, a workforce survey, which they have done a fair amount of analysis on, and this was a question that was raised. So that the great thing about that survey is a really wide range of folks responded to it and had just that question about the cost of doing the training and the cost of being out of work and so on. We are actually actively right now looking for funding from state organizations to do that for DC 0 to 5 training, to try to be able to do it with the costs covered by that funding, so that people would still have the 2 days out of work for the DC 0 to 5 training, but the cost of the actual training itself and the book and so on would be covered. I honestly can't tell you if there is any effort right now to secure funding to expand the training that's done out of the child treatment program and subsidizing that for folks. But I think it's a great policy ask and funding ask that we should be adding to the list.
Great. Can you describe what assessment tools are being used outside the mental health field as a baseline to know what further steps need to be taken? So assessments for classrooms and childcare centers.
So you're talking about assessments around social emotional development or for social determinants of health?
Well, interestingly, I believe that person was talking about social emotional health, and there is a follow-up question about social determinants of health. So if you can speak to both of those, I think that will address two people.
Sure. Well, I'm not aware in North Carolina about whether what tools are being used by our early childhood folks. I want to think that BITSI is one of the tools that they're using. I know Child First uses the BITSI. In primary care, folks are using the Ages and Stages Questionnaire Social Emotional, which actually is a pretty nice tool and does get at things like attachment and responsiveness, and that's for it. They have tools for 0 to 5. I know that there are, in primary care, folks are using the Survey of Young Well-Being of Young Children that has a brief social emotional screen in it, which probably isn't the most appropriate one for an early childhood setting where you really would have the opportunity to use something that's not that brief. But I would say probably the ASQSE or the BITSI would be the most common around that. Now, when you start talking about social determinants of health screening, I just did a national webinar just on some of the tools that are available in pediatrics, and it will curl your hair a tad. But there are some standardized tools out there. So the federally qualified health centers are using something called PRAPARE, P-R-A-P-A-R-E, which has a whole variety of questions in it. It's not very specific to early childhood, which is the issue, but it does get at housing, food insecurity, utilities, transportation, whether people have experienced violence in their home or in their community, those sorts of questions. There are a number of them right now. DHHS in North Carolina is working on getting it standardized that at least people in healthcare, in child welfare would be using questions to standardly ask about food insecurity, housing, transportation, and violence. I will tell you that there are some tools that are more specific to childhood, but the idea that you're going to find something that has a question on it for every last possible social determinants of health that's just not happened. Plus it would be pretty lengthy. Health Leads if you go to the Health Leads website, they actually have categories of questions that include things about young children around, like childcare and so on, that are validated questions. They will tell you what grade level the questions are. And so there are people very interested in using the Health Leads materials and for their community or so on, choosing questions in multiple categories that are validated questions and putting them together. So stay tuned, because you know that this is going to proliferate, that people are going to try to put these things together. The national organization called Child and Adolescent Health Measurement Initiative, CAMI, they are the folks who have developed the National Survey of Child Health. They have had a work group to put together a pediatric social determinants of health tool. It's 18 questions, I believe, and it addresses a lot of the standard housing, food insecurity, and so on, but it also has a few questions around that parent-child interaction, parental knowledge of development, those sorts of things that relate to those protective factors. I'm glad to share that, Tracy, if we could send it out to people if they're interested.
Sure.
But it's far from standardized yet, unfortunately. Or fortunately. We need to learn more about how we ask these questions. In the national projects I've been working on with the American Academy of Pediatrics, we've had practices from all over the country, training them about how do you ask families about social determinants. And the very important piece of that is not even so much what is the tool, but who is asking those questions and how are they asking those questions? And is it done sensitively? Because you can imagine that asking some of those questions could be felt as intrusive or, not well received by folks. So as much as we need to find a tool, we also need to know how do we talk about this and how do we do it in a way that's effective and actually helps folks. So that's a long-winded answer to that question.
We do have someone who is sharing some resources who says the CSEFEL project from the North Carolina Early Learning Network is a fabulous program and is relevant to licensed BK teachers, such as those in NC Pre-K and exceptional children programs. And she also notes that the Department of Health and Human Services funds a statewide program for childcare providers that uses the CSEFEL pyramid model framework, the Healthy Social Behaviors Project, and that statewide project offers technical assistance to teachers and licensed centers and training to childcare providers, all again through the Pyramid Model Institute. So there's some background for you. Let me see, we have quite a few questions still coming in. For those that are working with parents and primary caregivers, what other tools and strategies can we offer beyond our evidence-based curriculum, which is Incredible Years in Triple P, for families to raise socially, emotionally competent children?
Wow. In 25 words or less.
Yeah. You could do a whole
on
that.
Clarify to me, Tracy, that was working with primary care providers?
No, primary caregivers are parents, so whoever is... Oh,
primary caregivers, okay. See, I think, we had some lists, I had a little list on there of some things that have considered evidence-based in working with families, and certainly Incredible Years is one of those things. And the promotional piece of this, really, I think there are several, and I'm not speaking necessarily to those that are in early education or in primary care, but working with families to help promote resilience and promote protective factors and to be able to talk about those things. It's very interesting when we ask primary care clinicians to how do you talk to families about this. People really started talking about engaging the family around their strengths and how they enjoy their child and that sort of thing. So I think general promotion is a really important piece, but I don't think we can I think general promotion for everybody is a really important thing, but for families that you see that are really more at risk, as we start identifying risk, I think having more evidence-based programs is really the important thing. Practices have really taken to talking about strengths, encouraging families. One of the promotional things that we're actually doing with a lot of practices in the state is the program of Reach Out and Read, because that's not just handing a child a book when they leave the practice. It's talking to families about engagement and how that serve and return is going to promote their child's language and social emotional development. And people are very responsive to that sort of work, the promotional work. But I really think when we get into this, identifying people around social determinants and so on, the need for more evidence, availability of more evidence-based programs is very significant. And the question that we get is, when we've identified these things, who are we connecting families with, and what's available in my area or my county? So I don't know if that answers your question exactly, but I think, while everybody is very excited about the promotion piece, and we definitely want to do that, working in the area where we're starting to identify these needs, the need for us to really have evidence-based systems that are accessible no matter where you live is really important.
I think we have time for one final question, although there are still many here. And folks have asked for links to the resources that you've just shared, Dr. Earls. So if you send them to me, I will be sure they go out in the email to everyone. The last question is around children with special needs, and if there are unique approaches and tools and evidence-based programs to be thinking about from that perspective.
Wow, it's a great question. And certainly you can think of, kids with special health care needs, that there are particular needs around social emotional development. And quite frankly, I'm not aware a resource that specifically addresses the needs of those kids around social emotional development. And I'd be open to anybody else being able to tell me about that. That's not to say that those families might not benefit from the evidence-based therapies that we've already talked about, but in terms of specific programs that address that, I really think that that's, aside from some of the programs that work with families where the child has been identified as having behavioral issues associated with the autism spectrum, and even that is fairly limited. I'm not aware of specific programs to address that.
Great. Well, thank you. And thank you so much for being so generous with your time and sharing your expertise with everyone today. We will share a recording of the presentation and of the slides, as well as the links that were referenced at the end. And thank you so much, Dr. Earls, for all that you are doing, both in North Carolina and across the country, for our young children.
Thanks. Thank you, Tracy.